Good afternoon. Welcome to United Medical UMAC TV. Today is August 12th, 2022, Friday. My name is Kemal Erkan. I'm here with Sean Donovan. Sean, how are you doing?
I'm doing well. How are you?
Good. So we are gonna start our session, our episode today. We have our regular updates as we cover so many different topics related to healthcare, COVID-19, monkeypox, as well as we have a guest speaker from Brandywine Podiatry, Dr. Linda Civarelli. She's going to be with us in the next 10 minutes, hopefully. And then we're going to discuss some other topics as much as we have time, hopefully. So, Sean, we're going to start with the COVID updates.
Take it away. So, as we mentioned, we'll be beginning with the COVID updates for the week. We do have a cartoon in there on the first slide, and it's touching on the fact that during the COVID pandemic, everyone was looking for tests, COVID tests. There's a scarcity. We wanted to make sure we were able to track our conditions, symptoms for testing positive, negative. And now this similar event is taking place with the monkeypox, where people are trying to get tested, making sure that they're ahead of it. As we'll touch on a little bit later, the cases for monkeypox are actually increasing a lot now. We'll get to that right after the COVID number updates, but that was the cartoon that we wanted to touch on for this week. Overall, the COVID infections, the numbers have increased again. The U.S. at the top with around 80,000 new cases. The number you're seeing there was based on 2 days ago. And then with the overall cases, with the chart with the line of best fit, the red line on the graph, you'll see it is kind of plateauing there. Again, we always mention the Omicron variant was the highest during the winter, but this was creeping up the past couple of months, and now it's sort of plateauing as we go into the middle of August there. But overall, the severity of this COVID that people are experiencing, we think the symptoms are a lot less severe, and the mortality rate is lower than that of previous variants. So that's always important. Vaccination-wise, we are steadily increasing there around 0.1% in the state of Delaware, and then across the nation as a whole. For people being fully vaccinated, we're up over 223 million, almost 223.5 million, which is roughly 67.3% of the total population. And then now just touching on the monkeypox, as we mentioned in the last session, when we first found out about it, we had reached out to the state, seeing what their approach was, if they had any precautions and steps in place that they wanted to maybe prevent cases from being spread. But as we know, they kind of had a more relaxed approach, I guess, in our opinion, taking the seriousness. So now actually in the US total, we have almost 11,000 cases now, and Delaware, the state of Delaware, is up to 8. So we are seeing that number go up. If you look at the graphic, it'll show you the hot spots are the states that are in the darker shades of blue that you'll see across. It looks like New York, Florida, Texas, and California where we have the most concentration. But again, Delaware is at 8. And then one of the things,
I guess one of the issues that in these types of things, like, we want to learn from our mistakes.
Mm-hmm. Yep.
And COVID was a big lesson. And then that's why we actually reached out to the state right away. As soon as this, we didn't even have a confirmed case when this came out.
Correct.
Because we knew this COVID was so fresh. So then can we do actually better to prep ourselves, the society? But as you said, that didn't happen, unfortunately. Mm-hmm. Now, one thing that I want to remind people with the COVID, I'm hoping that people, they keep home kit for self-testing. Mm-hmm. Especially now the CDC actually lift the requirement for the quarantine. Mm-hmm. And because we have more cases, they're not as severe, but we have more cases. Yeah. So you do want to be able to test yourself right away. And then just recently I had to do that for me, and knowing what the status is important, and then being able to get that rapid test actually is helping. So make sure that you have home test kits for COVID at home. Mm-hmm. going back to the monkeypox.
Yeah, so back to the monkeypox. We did touch on this a little bit last week, but we did want to include more information and graphics here on the symptoms and some of the treatment plans and kind of the way it aligns. There's a lot of similarities between COVID and the ways we can prevent the spread, whether it's saying, keeping social distance from people, limiting contact, and then also that we want to make sure people are testing and tracking that. We know they did make vaccines available. We know that they will be most likely altering them a little bit, as we know there's different variants and mutations that happen in certain viruses. But we do know that overall it replicates that of the smallpox most closely. So the graphics that
the only thing that these things may change. Like today, they say these are the ways to. This is how it's spreading, but because it's still new and because they don't know, these are kind of like. I wouldn't just stay with these. I think the social distance is something that, although CDC lifted that now, maybe the 6 feet was an overkill. But with monkeypox, it's more like skin touch.
Direct contact.
That type of contact, and maybe it's a little bit more than the COVID. It's more difficult to get it. Just being in the same room with someone doesn't maybe do it, but I would still be pro-cautious and be careful. I think the habits that we learned from COVID, like I tell my parents, look, even there's no COVID, when you are in public transportation, if you're on an airplane, put a mask on because they're both over 65. Their risk from flu, getting severe flu and affecting them would be high anyway. So those are good habits that we learned before. Like when you see someone with a mask, it would be like kind of like weird, like awkward that you're looking at someone who has a mask. But now everyone is used to it. Now, some of the habits, and I'm not saying that you need to do it everywhere, but if you're on an airplane, I have a lot of unfortunately bad experience on airplanes. So like people not putting their socks on.
That's non-negotiable, right?
Not so clean and this and that. So I think the mask actually is a saver. So, but I think we're going to monitor the monkeypox a little bit more closely. Now, the state of emergency is pretty much everywhere, right?
Yep. We know that the Biden administration had declared that, I think it was earlier last week, that is being recognized as a state of emergency. So as we continue to track here, the cases are going up, but we're going to see, in my opinion, I don't think I've seen any severe deaths related to this, like number-wise, as exponentially as we did with COVID initially. So that may be something to pay attention to if we see the mortality rate compared to the caseload. But regardless, we are going to keep our eyes on this. As we said, we were tracking it from the very beginning, and we want to see maybe there are going to be new implementations put in play to help prevent, or also treatment plans that the state or government may have.
Sure. All right. Well, thank you for these updates, Sean. So I'm going to actually bring Dr. Linda Civarelli.
Hi.
Hi, Dr. Civarelli. How are you doing?
I'm great. Thank you. How are you?
Good, good. Thank you for joining us.
Thanks for having me.
And we are going to discuss peripheral artery disease. Now, before we start, if you can please introduce yourself and then the practice that you work with, and then we can start the topic after that.
Great. Thanks. Well, first off, thank you so much for having me. It's a pleasure to be here today. I am Dr. Linda Civarelli. I'm a podiatrist. I work at Brandywine Podiatry. I've been there in March, I believe, will be 15 years with the same practice, practicing in Delaware. We are the largest podiatry practice, I believe, in the state of Delaware. And I have the pleasure of working in our Middletown and Wilmington offices, but we have offices all over the state. So thank you so much for having me. And I'm going to be talking about peripheral arterial disease.
Yes. So now this is because you're a podiatrist, and then usually this topic is, I think it starts with the cardiologist, if I'm not mistaken, right? So we are going to actually look at it from the podiatrist standpoint, and then how you are working with our patients, as United Medical ACO has so many different specialties, serving more than 110,000 patients at the primary care level. And brand one podiatry is a big part of our specialty support. We always appreciate that. And then I think these sessions are also helping patients to get additional information from us. And then we do appreciate that. So I'm going to start our video loop so that you can actually start talking about the topic. And then if I have any questions later on, I will address those with you.
Great, thanks. Yes, it's interesting when you say that the cardiologists typically talk about this. That's one of the interesting things about podiatry is that we see a host of different diseases. We see the effects of them. So thank you for, having me on and allowing me to talk about this. Typically, probably discussed by either cardiology or vascular surgery.
So from the disease itself, if you can actually let us tell us like how this works, like at what point patients are coming to you, and what actually it is, like, and I know there are a lot of information that you're going to provide for us. So then we can go from there.
Great. Okay. So peripheral arterial disease, or PAD, occurs when plaques, these are deposits of fat in the blood, are inside of the vessels of the legs. People might be familiar with plaques in general around the arteries of their heart, but a lot of people don't know that the same thing can happen in the arteries of the legs. What happens when these plaques are in the vessels is it causes the arteries to harden and narrow. So it's sort of like your garden hose. When you put your thumb over the top of it, it decreases the area for the liquid to go through, and it increases the pressure. So a lot of people are aware of this happening around their heart and maybe even the vessels in their brain, but this also happens quite often in the vessels in the legs and the feet. Other people might refer to this just as poor circulation, and that is another term that's often used. It's very common. It's estimated that 1 in 5, so 20% of the population in the United States over the age of 70 has peripheral arterial disease. That means somewhere around 8 to 12 million people in the United States might have this. The good news is that a simple blood pressure test can detect this. It's called an ABI, and we'll talk about that a little bit later. The risk factors are a lot of the same risk factors that people know about for heart disease, risk factors for stroke, including smoking, sedentary lifestyle, diabetes, high blood pressure, or even a family history of stroke, of peripheral arterial disease. I have some notes here. Thanks. Warning signs. So, this is actually really interesting. Most people that have peripheral arterial disease, they won't have any idea that they're having this. It's been estimated that only a third of people that have peripheral arterial disease actually have symptoms. So you might have this, it might be building up, you might have this buildup of pressure, these plaques in the arteries in your legs, and you may not even know. By the time a lot of people are having symptoms, there may already be damage to these vessels, and that may or may not be able to be rectified. We'll talk about that. So what are the warning signs for peripheral arterial disease? The most common is cramps or tiredness in the legs. And that kind of presents in two different ways. And this is one of the screening questions that often your cardiologist or your podiatrist might ask you is, are you having cramps at nighttime? Are those cramps occurring more than like once a week? Is it, maybe just, okay, yeah, you do a lot of yard work, maybe you're a little dehydrated, happens every once in a while, but are you like consistently having cramping at nighttime? And that can be a warning sign. Another warning sign is something called claudication, and that is pretty regular cramping or pain in the legs, either in the thighs or the lower legs, that happens when you're exercising or walking. So oftentimes people will have to stop and rub the back of their leg or rub their thigh because it's hurting when they're walking. And those are definitely warning signs for peripheral arterial disease. Also, foot and toe pain that disturbs your sleep. And what's happening is that as we're sleeping, our heart rate decreases, our blood pressure decreases, our muscles aren't moving. And so if you have these plaques, these hardened arteries, the blood may not be flowing all the way to your feet. And that's what's causing some of that pain. And then lastly, wounds on the legs. So we often think about wounds as signs are associated with diabetes, but you can also have wounds that occur because of peripheral arterial disease. Typically, these wounds are a little bit different than the purely diabetic wounds. So diabetic wounds, and there's a lot of overlap in these wounds, but if you see someone that has, or if we see someone that has a painful, non-healing wound, especially on the outside part of the leg, typically those are because of peripheral arterial disease. So it's just really important. If you're having leg pain, it's not normal, and you definitely need to talk to your doctor. I do want to point out that that's different than leg pain that is occurring all of a sudden. Obviously, any kind of sudden leg pain, sudden swelling of the leg, redness of the leg, shortness of breath, those could be signs of a blood clot, and those would be an emergency. You should definitely seek care right away. Peripheral arterial disease presents a little bit slower. So it's like getting worse over time. And, oh gosh, I was having cramps once a week. Now I'm having them every day. So is it serious? Yes, actually, it is quite serious. Like I said before, somewhere around 8 to 12 million Americans have this. It is associated with heart attack and stroke. And the reason why is because when you have hardening of the arteries in your legs, not surprisingly, you probably have hardening of the arteries around your heart and potentially maybe even in your brain. And that's because there's reduced blood flow in the legs. So people, again, might have that pain when they're walking. One of the most serious effects is amputation. As a matter of fact, diabetes and peripheral arterial disease are the two leading causes of non-traumatic, so meaning like you're not in a car accident or you don't have, something else going on, non-traumatic amputations in the US. And it actually can really decrease your quality of life. So again, if you're having leg pain, seeing your podiatrist, seeing your primary care doctor, even your vascular doctor, if you have one already, or your cardiologist, these are all people that are equipped to test. So how to test? You can get a pretty simple test. It's called an ABI, and it's a blood pressure cuff that everybody's familiar with. It's typically taken on the arm, and then that same blood pressure is taken on your leg. And then we look at an index of those two numbers. That can give us a really good idea of what's going on and how serious it is. It's a simple test. You don't really even have to go see anyone special to see it. Most of the doctors can do it right in their office. So what if you have peripheral arterial disease? What does that mean? What do you do? So obviously you need to have a conversation with your doctor about quitting smoking. That's one of the leading causes of peripheral arterial disease and is definitely not helping. Also lowering your blood pressure. So taking your blood pressure medications exactly as directed by your doctor and monitoring your blood pressure. Also your cholesterol. And then managing your blood glucose if you're diabetic. Also talking to your primary care doctor or a nutritionist about an eating plan to try to lose a little bit of weight and control your blood pressure. One of the most important things is to get exercise. So one of the common questions that people ask me is, well, I have peripheral arterial disease, so my legs hurt when I exercise. What do you want me to do? Well, believe it or not, there's actually exercise programs out there specifically for people with PAD to help them get blood flow to their legs. Because when you're exercising, you're actually expanding those vessels and helping fight against those plaques that are in there. So how is it treated? It's primarily treated with lifestyle changes. These are, we talked about smoking, exercise, diet, blood sugar. Controlling risk factors for cardiovascular disease, going to see a cardiologist. Lastly, there are also some medications that can be taken, and eventually sometimes surgery is required. Lastly, when you want to discuss peripheral arterial disease with your doctor, just make sure you have your medications ready, and your social history, and many people even have like a questionnaire.
So, with these clinical episodes that we have, is one way of really actually learning a lot from what you guys do, and because I do so many of these days, so I train myself to pay even closer attention, so that I can actually pick up more stuff. Now, as you know, we do kids conferences on a daily basis. Every morning, there are a group of patients, and I'll just describe them as like patient who has diabetes, and they never have only just diabetes. They have also blood pressure issue. Then they never had that issue, only two together. They have vascular issues, and they may have chronic kidney problems. These are kind of like group of disease, almost like they're all traveling together, or they live together. So like I call them evil sisters. So they are always there with one patient. There are four or five different chronic problems. And what's important, I guess, for our patients is this is one is treatable, but I think getting to the specialist in a timely manner, that makes a huge difference. Do you see that with your patient base, that they're just kind of like waiting until the last minute and then it's already kind of out of control?
That's a great question. There's really a wide gamut. I mean, I do have to say that there were a lot of people in the last couple of years who have delayed care. That's definitely something that's not unique to podiatry. Many people over the last couple of years have really been concerned about COVID and haven't been coming out and being cared for. So maybe have put off care. I have to say in the United Medical ACO, we see a lot of patients that are referred by their primary care doctors that, are in to see us. Many of the primary care doctors in Delaware are really on top of this. And I find that really fantastic that there's a lot of prevention and education going on the primary care level, and then can be sent to the specialist level.
So the other thing is that I guess when we ask patients exercise, they feel like, actually earlier today, I asked Sean. Sean actually is in the same room with us right now. He's not on the video, but I asked him if he works out. And then the expectation, I guess, is like if they are really working hard, like in a way that like they go to the gym every day, spend like 3 hours. That's not what we are talking about, right? When we say exercise, this is just like walking around the block, going to the mall or going to the shopping, grocery shopping. So like just activity, like that just keeps them enough in a way that they don't sit, like right now, like in this session, so I'm sitting in a certain position. So if I keep sitting on this position for like 2 hours versus if I'm right after this, if I actually get out and stretch and then walk around the building, that makes a big difference, right? So these are like small touches that actually makes a huge difference. So we don't want to overwhelm the patients saying that, look, you have to now work out like 2 hours a day, which is not going to actually even help. So can we just talk about that a little bit? So what's the perception out there from the patient standpoint in terms of the exercise that they have to do?
That's, another great question. Oftentimes people think that when we're talking about exercise, we're talking about training for a marathon or, doing a triathlon or something. That's not in any way what we're talking about. As a matter of fact, the vast majority of our patients in podiatry are certainly in the way that I practice, which is generally general podiatry, is, these are people in 70s and 80s and even 90s and above, and really just moving, walking, making an effort to stand up and move your body once a day. And that actually doesn't even apply only to older people. As our jobs become more sedentary, more computer-based, for all age groups, we recommend, including kids, right? A lot of kids, especially in the last couple of years, were doing Zoom school. And that was, you got to get up, you got to move around, you got to act, that all counts as exercise.
The other thing that now, because I have my both parents, one 71 years, the other one is 81. So we have to talk to them regarding their health, and then make sure that they are actually taking care of themselves. And, my mom, I always use her as my example, and usually it's not a good one. So she never wanted to give up her good shoes, like the fancy shoes. So she said, that's my thing. But then she had diabetes, and then she had blood pressure issues, and then now it's more control. But I think the footwear, at certain point, they need to really give up that fancy shoes and then just get something more healthier, comfortable, right?
Now, you're not putting me between you and your mom, right? Okay. That's a tough question. I also like a pretty shoe, and it evolves with time, right? You have to understand your risk, and making sure that you have shoes that, for the most part, fit you well, aren't going to cause any kind of wounds. I think that's the most important thing. However, I'll say that, if your mom really loves her great shoe and she knows that it fits her well and isn't going to cause any kind of blister or anything, carefully wearing something occasionally.
Yeah. That's a very politically correct answer. Good job.
I have a mom too.
No, this is one of the disease that needs to be diagnosed. But once they are diagnosed, how often do you need to see them in the office? How often the patient should be followed up?
So for peripheral arterial disease, they'll typically follow with a couple of different specialists. So one would be the vascular doctor or the cardiologist. So, the cardiologist kind of does the pump, and the vascular doctor does the plumbing, and some cardiologists do the pump and the plumbing. So whoever it is, whether it's your cardiologist or a vascular doctor is one, and they'll typically be seen a couple of times a year. We'll see them in our office for care as much as 4 times a year. Sometimes, we can, we'll space that out depending on the severity of the disease and the need, and also the risk factors.
All right. So I think, again, just like any other disease that I see, being proactive and then taking early actions before it gets too out of control, and then staying in touch with your primary care and with the specialist, following up with those healthcare providers. I think those are the most important parts. So, in a way, you mentioned something earlier with United Medical ACO, the culture, the clinical culture that we were able to build and establish in the last 6 years. The clinically integrated, meaningful clinically integrated group is what we became in time. And that's part of the case conferences. So when we see the patient with issues like they may have. Some of, as you know, like some of our elderly Medicare patients, they are on a limited income and they don't know what's available to them to take care of themselves in a better way. There are different things available in society, in the community, and our social workers are actually helping. And we discuss these in our case conferences. In some cases, we see the patient didn't follow up with the podiatrist. We make sure they get that extra push from our central office. And I think that makes a big impact on the way that we are practicing today. And that actually makes us more successful, and in a way that maybe we are unique in that setting because we are not a hospital system. We are private, right? We are all private groups. So, and being able to do that in a meaningful way, that actually is really important. And I'm really happy that we are able to do that. Anything you would like to add related to this?
I'd just like to reiterate that if anybody is having leg pain, whether it be sudden onset leg pain, which would be an emergency, or a leg pain that's getting worse, thigh pain that's getting worse, it's not normal. And it's definitely something that I would call your primary care doctor about and have them evaluate you and then see if potentially you should go see a specialist.
All right. Well, Dr. Civarelli, you're one of my favorite podiatrists. We know each other for a long time, and it's always great to have you on our episodes. You were part of the diabetes events a couple of times, and I really appreciate you taking time and talking to us. So hopefully we'll see you again in the next couple of months.
Thank you so much. And again, thank you for having me. It's always great to be here.
Thank you.
Thanks.
So, Sean, you are back in. So
I'm returning.
And then let's see what we have.
All right.
We want to close it.
We have a couple different ones here. So we're going with the economy first.
Okay.
Yeah, so one of the things, if people are paying attention to the news lately, we had the Schumer bill being passed. That was a tax increase. It was approved. It was at a 50-50 standstill. And then with the vice president casting her affirmative vote, it did pass. It was one of the most narrow, I guess you could get.
I'm not going to pay any more taxes than what I'm already paying.
Yeah.
It's almost at 40%. So if they want us to stop working, they can increase the taxes, no problem.
Right. But yeah, it's
one of the worst things. You know, some politicians don't really understand when you increase the tax. There's a point where you actually see a big decrease on the overall production.
Mm-hmm. Threshold. Yeah.
Like if I have to pay more taxes, then what's actually motivating us to grow our business?
Yeah.
So that's the part that I think these guys need to understand. Increasing at this point right now, we are at the highest level. If this is being increased even more, good luck.
Yeah, as they're saying, this combined with inflation that's going on and the recession type economy, you're looking at stagflation is bound to happen, where you're gonna, like you said, you're gonna see no more growth, and obviously it's not good for the people. So there's a lot of controversy on this being passed, but it was. So
it would be a huge disaster.
Yeah.
So, but more like the higher taxes is never the right thing to increase the government's income. So you can actually spend less. So there's a lot of unnecessary spending right now. And
Great.
You know, in my power at least, I would fight for that, because that's not because we don't want to pay more taxes if it's going to help, but it's not going to help. So I may still do what I'm doing, but there will be other people who are not going to actually grow their business. When we don't do that, so what's going to happen? The things are going to get, businesses are going to get smaller. there will be less employment opportunities, and they really don't understand it, unfortunately. But I mean, we also know that these people don't understand a lot of other things. So as you're now studying these a little bit closely, unfortunately, being from was born in a country other than United States, I thought certain issues would only happen in those countries. Like I was born in Turkey, so I thought that there are certain things unique to those less developed countries. Let's categorize them. And then I thought there were certain things would never happen in the United States, and that actually is no longer the case. And it's not just this; that so many other things. What's been happening in the last 2 years is extremely disappointing. And I'm hoping that we need to really this doesn't become the permanent culture of our future. So because this is not what we sign up for. But this doesn't mean that they won't make these mistakes. I mean, there are a lot of unnecessary spendings. Government is way too big. There's no need for that. And I think they can kind of scale down a little bit.
Yeah, I would definitely agree on that. Like you're saying, these impacts on the larger level that people may not necessarily think is going to impact their day-to-day life, you'll see the trickle effect and the domino effect. And later on, you may not see an immediate impact, but as you're saying, with these maybe smaller businesses, that there's going to be this economic kind of plateau, and you're not going to see this growth. And then you're saying less jobs and opportunity costs that are associated with things like this is just sometimes it's not retained, at the immediate time of it, but later on you'll see these impacts come back to get you.
All right. Now, we had the local update, so I just want to actually get that one before it's too late.
Sure.
Let me see. Every time I feel these videos are in perfect order.
The last second that read.
One of them is missing, and then that's the one that I was looking for, but I got it right now. So let's see. Now there's a change coming up in Delaware. This didn't hit the news yet, so as we always borrow news from others, this will be the time for others to borrow news from us, and it's just uploading. So what's happening in the it's acting up. Hold on 1 second. Go ahead.
Okay, so just to give everybody a brief intro on what we're going to get going here is different hospitals in the state of Delaware and the different tiers that they are at level-wise, which their trauma care varies depending on what classification they are at. And as you know, obviously you are more familiar with the different hospitals and the tiers that they are at, but in the state of Delaware, we have the Christiana Hospital. It's our regional level 1 trauma center. And just historically, it was around 2017 that the hospital we're going to be talking about in this example, St. Francis, I believe it was 2017 when they got clearance to move from a level 4 up to a level 3 trauma center.
So there's more into that.
Yeah. So how that all ended up taking place here. So as you will enlighten us on a little bit here, the Surgeons for Emergency Care development of this organization to help staff and fully staff St. Francis, who had all the supplies necessary to be operating at a level 3 trauma center, but they were having staffing issues. So you, along with various, cohorts of yours, helped get the SEC established, and that ultimately was able to bump St. Francis to a level 3 trauma center by staffing these qualified surgeons at this location.
So now this is actually, let's just actually take a step back and make sure that people understand why we are talking about this. The reason St. Francis Hospital is important in the state of Delaware, especially in the Newcastle County, is because we do need that competition and access to care for those patients who are, especially in the inner city. As everyone knows, there's only one other hospital systems which is the big giant Christiana hospital. Now they bought a couple more hospitals around the outside of Delaware.
Monopoly.
So it's becoming a big monopoly. The healthcare cost mainly is coming from the unnecessary overpriced hospital expenses. And if you don't have competition in Delaware, that's going to be a disaster. Now, we always supported St. Francis so that St. Francis would actually stay in business. So the worst thing would happen. They're also part of a really big national group, but in Delaware, they're not being successful. That actually is not a surprise because a lot of leadership change there.
Yes.
So when this latest news came up, because I'm also in the middle of writing a book regarding the different business entities that we have and experiences that we have. So this was kind of convenient for us, kind of really refresh everyone's mind and what happened. So Dr. Aziz Erkan and myself, we are the reason for the trauma center, trauma at St. Francis to go from level 4 to level 3. Because prior to that, in 2013, when they didn't have even general surgeons going there. So you mentioned SCC, Surgeons for Emergency Care was one of its kind, like unique setup for surgeons. When I set that up with Dr. Erkan, there was no other businesses similar to that because we had like legal trouble with malpractice companies because they didn't understand how I can put like 7 different groups, 14 different surgeons in one. And because of all those, when we overcome those problems, it became a very unique group. So what it was doing was providing emergency general surgery cases, surgery services. So we started at Christiana just to kind of make it like kind of like put it in perspective in a way that when before this, these surgeons were taking calls, but they were not on site. With Surgeons for Emergency Care, one of the biggest difference that we did, we actually made this service available on site 24/7. So this was a huge service because now your response time is different. When you can do your surgeries, it's different. And it improves the quality of care tremendously. And they benefit from it. So we have contracts. And we were doing really well. And then we took this service to St. Francis. St. Francis, from the number of beds that they have, they should be, let's say, 17, 18% of the total patient base, but they're not. Why? Because patients are not going there. Why? Because EMC, the ambulance service, they don't take them to St. Francis. The law says they need to take the patient to the closest hospital. Now, I live closer to St. Francis. So, and I actually, it's kind of like a side joke that I tell my tennis instructor that if something happens to me, don't take me to Christiana, take me to St. Francis, because the wait time is not going to be that long. So, so you as a young man, kind of like high risk for appendix. So if if you have that emergency can be like a 9-hour wait time at at Christiana Hospital. This is real. Okay. So now what we did, I brought all these surgeons with Dr. Erkan into St. Francis. They were able to get more business as they were better established. They said, well, now we need trauma service. Now, level 4 to level 3, this ambulance service is important. So once they are able to go from one level to the next, the ambulance has to take that patient if they are suspected for trauma to the closest one. So now St. Francis was able to get business from the emergencies. So because everyone was going to Christiana. Now, unfortunately, when I heard about this problem, this issue, and now they are actually getting back to level 4, that means that's trouble for St. Francis. That's trouble for the community that we live in, because if the St. Francis is not able to survive, then we're not going to have options. There won't be any options. So that's why it's important. But there was a different issue. I mentioned the leadership. leadership changed so many times and is lacking still. So why is because we are an accountable care organization with 115,000 patients, so they should be working with us very closely as they need more business. They didn't. Instead, they took me and Dr. Erkan out of the Surgeons for Emergency Care, the group that we established, and then they bypassed us. They contracted with these low-life surgeons who are not qualified to be like a trauma director, and yet today they are now closing the program. We built that all together, and we put so much time and energy, and then bad leadership choices, bad leadership can lead you into a disaster, and that was one of those. Now, we still want to help St. Francis, and we are still talking. I mean, I think we have a meeting coming up, but this is affecting our patients, so that's why we are actually talking about it. So it's a problem that I think we are going to face, and I'm hoping that it is not going to be. If they were to go back to level 4, that's going to be a huge problem.
Yeah.
So now Closure Chester is bought by Christiana. Jennersville, around right over the border, bought by Christiana. That monopoly, that big giant, efficiency-wise, we have no problem. But once they're in control of your life, forget about everything else.
Yep. And as you know, the cost associated with that going to these hospitals is much higher.
Absolutely, that's all about cost.
Yep.
But it's kind of sad that we are at this point after spending so much time, putting so much energy, and just because poor decisions, evil decisions, jealousy, whatever you want to call, that's why we are where we are today with St. Francis, and that's a shame. So, but we'll actually update everyone as we go, as we find out more information. So we'll stop here for today. We have a couple other stuff, but I don't think we have time for all. Now, we have a new journey starting with our bariatric surgery. So 3 new patients today, they are going to decide what type of surgery they are going to get in 10 minutes. We are going to be with Dr. Erkan for Bariatric Friday, and hopefully we can impact their life in a positive way. So, John, thank you for joining me, and thank you for listening to us. We'll be back next week, and we'll be back in 10 minutes for the Bariatric Friday. Thank you.
Bye.